Okay, so previously we had gone through ectopic pregnancy. Today we are going to discuss the second differential diagnosis of pervaginal bleed, which is abortion. Before going into the details, let me tell you, when I had my Pmdc exam back in 2019, there was 2 questions from this section. So focus on USG findings and pervaginal examination findings. Remember, clinical exams are all about diagnosis, investigations, and management of diseases. So pay less attention to etiologies and pathogenesis of the diseases, because in step 2 exam no one is going to ask you about what is the etiopathogenesis of this disease. But you should be able to recall that from step 1 course. Remember, when you're preparing for this step 2 exam, it also covers the course of PLAB 1 and Middle East exams such as SLE. Whatever the source you're using for these exams, make sure you understand and get the basic concept. So stay tuned, grab a cup of coffee, and let's begin with abortion. Abortion is defined as a pregnancy that ends before 20th week of gestation, or a fetus that weighs less than 500 grams. It's also defined as spontaneous expulsion or forced extraction of product of conception. Almost 80% of spontaneous abortions occurs before 12th week of gestation. Now pause the video and imagine and think for a second that what could be the possible etiologies of abortion. Imagine this is a young female. She is pregnant. This is her fetus, and this is placenta. The etiologies may include maternal factors, fetal factors, and placental factors. Let's study one by one. Fetal factors may include chromosomal abnormalities and developmental defects, whereas maternal factors include anatomic abnormalities such as uterine anomalies, infections like STDs and tortuous infections. Immunological factors may include autoimmune diseases, for example SLE. Endocrinological factors include maternal diabetes and hyperthyroidism and many more. Malnutrition and trauma as well. Placental factors include placental insufficiencies. Types of abortion. Abortions are mainly divided into 3 types: spontaneous abortion, induced abortion, and recurrent abortion. Today mainly we are going to focus on spontaneous abortions and its subtypes. Okay, it have got 6 subtypes. Let's study one by one. Threatened abortion. Threatened abortion is simply defined as when there is a threat to placenta. For example, a woman is doing heavy workouts and it may result into disruption of placenta slightly from its bed. That is labeled as threatened abortion, as there is a threat to placenta. Inevitable abortion. This is important, high yield from exams point of view. Inevitable abortion is when the process of abortion had begun and nothing can stop it. Why? Because here the cervical os is open and cervix is already dilated, so it's led to abortion. Incomplete abortion. Incomplete abortion is when some of the fetal parts are retained within the uterus and some of the fetal parts are retained within the vagina. Complete abortion. Complete abortion is defined as when there is a completely expulsion of the fetal parts. Septic abortion is the abortion. It's a kind of infection which occurs after any type of these abortions. Missed abortion. Missed abortion is when there is an intrauterine death of the fetus. Let's study in detail. There is a threat to abort, but pregnancy can still continue. Why? Because here the cervical os is closed and cervix is not dilated. Just the placenta gets slightly disrupted from its position. General physical examinations. This slide is very important. This slide makes you to help diagnose the case of abortion. She will be complaining of pervaginal bleed. On USG findings, there will be heart activity will be normal, and on PV examination, cervical os will be closed. Treatment. Conservative treatment always advise bed rest, avoid exertions and habit lifting. But in order to augmentation of pregnancy, to enhance the pregnancy, inject beta-HCG and progesterone. This is only for the satisfaction of the patient, otherwise bed rest is enough. Okay, let's study a case. 22-year-old female at 10th week of gestation presents with painless small bright red pervaginal bleed. On examination, these are pervaginal examinations, that external cervical os is closed. USG reveals fetal cardiac activity is present. So what important here is, it's not possible that they will give you a case of abortion and they are not mentioning USG findings and pervaginal examination findings. So they will always give you clues which will help you to diagnose the possible case. Here this is the case of threatened abortion, as her external cervical os is closed and fetal cardiac activity is also present. Inevitable abortion. When the process of abortion had begun and nothing can stop it. This is simply because the cervix got dilated and the os is also open. She'll complain of heavy pervaginal bleed. On pelvic examination, you'll see on pelvic USG, you'll see fetal cardiac activity is present. And on pervaginal examination, our cervical external os will be open. Treatment. If she presents within 12th week, then go for suction and curettage method. If she presents after more than 12th week, then induce labor via injecting oxytocin. If this process fails, then go for DNC method. Incomplete abortion. When product of conception is partially retained and partially expelled, it means some of the fetal parts should be in uterus and some of the fetal parts will be in vagina. She'll be complaining of pervaginal bleed with clots and passage of fetal parts. When you go for the pelvic ultrasonography, it will reveal some of the fetal parts in uterus, and on PV examination you will find fetal parts in the vagina. Treatment. If she comes under unstable condition, then always resuscitate the patient by maintaining vitals. Then go for the manual removal of fetal parts from vagina and induce the labor by injecting oxytocin. If it fails, then go for DNC method. Complete abortion. When product of conception is expelled completely. She will be complaining of fresh pervaginal bleed with clots and passage of fetal parts. Because it's a complete abortion, she will come to the clinic after when she had aborted the baby by herself. USG pelvis will reveal no fetal parts in the uterus and there will be no fetal parts in vagina. Missed abortion. Intrauterine fetal demise and uterus makes no attempt to expel it. It simply means that there is an intrauterine death of the fetus and the fetus is still retained within the uterus. The additional clinical features here will be regression of pregnancy features. For example, there will be decreased nausea, vomiting and breast engorgement. There will be loss of fetal movements and there will be the gestational sac won't be increasing in its size. This is here very important differentiating point from others. You'll only find these findings in case of missed abortions. If they'll give you in a case that there is a decreased fundal height and uterus will be smaller from its date, then it means it's a case of a missed abortion. Now, as the fetus is dead and the size of gestational sac is not increasing, so the uterus, the fundal height will be smaller than its dates. USG pelvis. You will find absent fetal cardiac activity as fetus is already dead. Mild pervaginal bleed. Treatment. Conservative treatment and active treatment. Maybe the uterus itself enters into the labor phase. If not, then go for suction and curettage. If more than 12th week presentation, then go induce the labor. If this fails, then go for hysterectomy. This is the one. It's simple like the C-section. Cut the uterus, take the dead fetus out and then stitch it back. This is the only case, in case of missed abortion, this is the one which carries a high risk factor for DIC. Septic abortion. Infection after any type of abortion is called septic abortion. Risk factors may include unsterilized instruments, unhygienic methods of abortion, and gram-negative bacteria such as Pseudomonas and Klebsiellas. This is differentiating point here important. She will complaining of mucopurulent vaginal discharge on pervaginal examination. You will see along with fever, malaise, anorexia, and mild pervaginal bleed. Complications, it can lead to septic shock and DIC. On examination, you will see increased pulse temperature. On pervaginal examination, there will be mucopurulent discharge. There are various investigations that you can go for it, for example, CBC, WBCs, USG abdomen, vaginal swabs, culture staining, and sensitivity methods. What important here is this is very high yield from exams point of view. USG abdomen, you will find a gas shadow in the uterus. Treatment, always resuscitate the patient under unstable condition. Antibiotics for mild cases, go for ampicillin, gentamicin, and metronidazole. For severe cases, go for ceftriaxone and metronidazole. That's all about all subtypes of spontaneous abortion. Thank you.